Hello everyone. Today we're going to talk about maintenance and assessment of treatment outcome. So our lecture today is going to be divided into two parts. The first part we're going to talk about maintenance, which basically we're going to be revising the information that was given to you from last year, and then we're going to talk about assessment of treatment outcome. Going through the outline for the first part, we're just going to give some information in the beginning, and then we're going to discuss the goals, the objectives, and the rationale of supportive periodontal therapy. And then we're going to talk about the maintenance program and what we do in the maintenance appointment, and of course the classification of post-treatment patients, and when to refer patients to the periodontist. First of all, we have to know that periodontal treatment is basically um, going through systemic evaluation of the patient's health, and this is what we do in the clinics through gathering information, medical history, family history, social history, dental history, and then the periodontal charting and examination, and then the therapeutic phase to control any active disease, followed finally with the corrective phase involving periodontal surgical procedures. And the most important part is the maintenance phase that should be ongoing. So we know that in the third World Workshop of the American Academy of Periodontology, the the maintenance phase was renamed to the supportive periodontal therapy. And the importance of this maintenance therapy is, like, what is the important thing for maintenance therapy? We want to prevent tooth loss, so we want to preserve the teeth. Also, another problem is the recurrent periodontitis, which is 5.6 times greater risk for tooth loss in non-compliant patients. And here we have to highlight the importance of motivation and dealing with patient's compliance, because this is one of the major causes of recurrence of periodontal disease. And there is also 50-fold increase in probing and attachment loss after successful regeneration therapy, regardless of how successful the treatment is. If there is no sufficient maintenance phase and compliance to the patient, there will be recurrence of periodontal disease. So basically, as I mentioned before, motivational techniques and reinforcement of the importance of the maintenance phase before performing any definitive periodontal surgery is very important. And this is where patient education is really important. So here you can see that we have phase one, reevaluation, and then phase two, where we do most of our surgeries, and then phase three with restorative, followed by phase four maintenance. This is actually not the right way or the division of the phases. Maintenance actually should be ongoing once reevaluation phase one is done. So it should be ongoing regardless of whatever you're going to do to the patient, if you're going to be in phase two, periodontal surgeries or endodontic surgeries, or phase three, where you're going to do restorative and orthodontic phase. So it's very important to note that maintenance starts once you finish reevaluation of phase one. So what are the goals of supportive periodontal therapy? So according to the American Academy of Periodontology position papers, we have three important goals. So as we mentioned, that we want to prevent or minimize the recurrence and progression of any previously treated periodontal disease, whether it was gingivitis, periodontitis, or periimplantitis. So we want to prevent or minimize the recurrence of periodontal disease in patients who have been previously treated. Then we want to prevent or reduce the incidence of tooth loss, which is very important, by monitoring the dentition and by any prosthetic replacement of the natural teeth. So this takes us to the third part, to increase the probability in treating in a timely manner other diseases or conditions found in the oral cavity. So we want to prevent any past diseases, prevent new diseases, and reduce the incidence of tooth loss. What are our objectives of supportive periodontal therapy? So we want to preserve the alveolar bone support, which can be detected on the radiograph. We want to maintain a stable clinical attachment level. We want to prevent any further attachment loss. Reinforce and reevaluation of proper plaque control done by the patient, and maintenance of a healthy and a functional oral environment, like in total. What is the rationale of supportive periodontal therapy? So, as we mentioned before, recurrence is a problem, and the reason of recurrence could be due to incomplete subgingival plaque removal, presence of the bacteria in the gingival tissue in chronic and aggressive periodontitis cases, the microscopic nature of the dentogingival unit healing after periodontal treatment. This is one aspect. The other aspect that subgingival scaling will alter the microflora. Okay, we're going to talk more details about recurrence. So the first part, when it comes to incomplete subgingival plaque removal, what is the problem with incomplete subgingival plaque removal? So this will cause continued loss of attachment without the presence of clinical gingival inflammation. Presence of the bacteria in the gingival tissue. So bacteria may recolonize the pocket and cause recurrent disease. Bacteria associated with periodontitis can be transmitted between spouses and other family members. The dentogingival unit healing, as we know, like after scaling and non-surgical periodontal therapy, usually the healing is going to be through a long junctional epithelium. The problem with the long junctional epithelium is that it's weaker and inflammation may rapidly spread and separate through this long junctional epithelium. The second part, where the subgingival scaling alters the microflora, once scaling is done, there will be a decrease in the motile rods for 1 week, with a marked elevation in the cricoid cells for 21 days, and also a marked reduction in the spirochetes for around 7 weeks. So this is very important because then we're going to know the importance of the maintenance interval. The return of pathogens to the pre-treatment level will occur in 9 to 11 weeks post-operatively. And this is why the 3 months maintenance interval will prevent recurrence based on the microscopic monitoring of the subgingival flora. And of course, the subgingival scaling will alter the pocket microflora for variable but relatively long periods. And these numbers are very important because, as I mentioned, we want to prevent the return of pathogens to the pre-treatment level and then also reduce the incidence of recurrence. Going to the maintenance program, the maintenance appointment is divided into 3 parts: the examination and evaluation, the treatment, the report, cleanup, and scheduling. What we do in the examination and evaluation is similar to the first appointment when you see the patient for periodontal examination and charting. Basically, you're going to record every changes from the last evaluation in the medical history, any restorations, prosthetic replacements, caries, occlusion, mobility, gingival status, probing depth. Also, you're going to do analysis of the current oral hygiene status, if it's improved, if it's the same, if it's worse, and evaluate any existing pathology of the oral mucosa, radiographic examination upon, of course, the case selection and what it really needs. You're going to detect the bone height, any repair of osseous defects, occlusal trauma, or any periapical pathologies, and caries, of course. So it's very important in the examination and evaluation, you're going to update all the previous information that you have done in the first appointment. And you're going to also monitor and evaluate and assess the patient's plaque control, which is going to be reflecting in the gingival status and the plaque index and the bleeding index. So your checking of the plaque control must be reviewed and corrected until the patient will demonstrate the necessary proficiency. Radiographic examination of recall patients for suppurative periodontal therapy must be individualized depending on the initial severity of the case and the finding at the recall visit. These are compared with findings on previous radiographs to check the bone height and look for repair of osseous defects, as I mentioned before, any pathology, any changes, any recurrent caries, or signs of trauma from occlusion. So the interval and the protocol of when and how often do you take the radiographs depends on the periodontal status of the patient and if the patient is high risk or not a high risk for caries. And of course, if the patient is free from periodontal disease, the interval will be longer, but if the patient has history of periodontal disease and is not under control, then it has to be shortened. So in the treatment, the required scaling and replaning is going to be performed if needed, of course. Otherwise, only prophy and oral hygiene instructions going to be given. And it's very important not to instrument normal sites because actually this will cause loss of attachment that we want to avoid. If needed, irrigation with antimicrobial agents for any remaining deep pockets, and then scheduling. You're going to actually determine the status of the patient, and according to the current situation and periodontal status of the patient, you're going to schedule the next maintenance appointment and if the patient needs to be referred to the periodontist or other specialties. Okay. So let's ask a question like, what is the primary factor causing recurrence of periodontal disease? So there's one major primary factor, and there are many other factors. But the first one that comes in mind is the inadequate plaque control. And of course, the bacterial byproducts that are found in the plaque deposits. Other factors are failure to remove any potential factors favoring plaque accumulation, incomplete calculus removal in areas of difficult access, inadequate restorations place, failure of the patient to return for periodic checkup, and this is why compliance is very important, and presence of any systemic disease, especially if it was uncontrolled, and the most highlighted one is, of course, diabetes. Now we go to the classification of post-treatment patients according to Marin's classification. So as I told you before, recall interval for the first year should not be longer than 3 months. Long-term preservation of the dentition is closely associated with the frequency and the quality of these recall maintenance appointments, and it varies, of course, from one group to the other. The patient can improve or relapse into different classification with reduction or exacerbation of the periodontal disease. So they are not constant in one group. They cannot be classified and stay in that group. They actually can improve or worsen. The classification is first year patients. We have class A, class B, and class C. First year patients, if the patient had routine therapy with uneventful healing, then the recall interval can be up to 3 months, but again, do not exceed 3 months. But if it was a difficult cases with complicated restorations, procedures with furcation involvement, some poor crown to root ratios, or poor patient compliance, then the interval should be shortened to 1 and 2 months. And this is most probably the cases with your patients here in the school. With Class A, excellent results are well maintained for 1 year or more. So if the patient was a patient with history of periodontal disease, but the results were excellent and the patient displays very good oral hygiene, minimal calculus, no occlusal problems, no complicated prosthesis, and no remaining pockets, and no teeth with less than 50% of alveolar bone remaining, then the interval can be between 6 months to 1 year. With Class B, it's basically patients with periodontal disease that have been treated, and there are generally show good results that are maintained well for 1 year or more. Um, so here, the interval is not going to be as prolonged as in Class A. It's going to be 3 to 4 months, depending on number and severity of factors. Um, um, like if we have any systemic factors, if any environmental factor patient is smoking, the bleeding index, a number of deep pockets, all the factors that have been documented in the maintenance. Okay, if there are many risk factors, then it's better to see the patient every 3 months. But if they don't have a lot of risk factors, then 4 months can be the interval for this maintenance for the Class B. With Class C, after periodontal therapy, it's still a very poor result, and there are several negative factors. Usually, the patient has more than 50% of bone loss, with many teeth that are considered hopeless and indicated for extraction either at the phase of treatment or later on during the maintenance phase. Um, in this case, we consider, as I mentioned, retreating some areas or extracting severely involved teeth. And here it's very important to monitor these patients very closely because usually they're at high risk of recurrence or needing retreatment. And here the interval is going to be between 1 to 3 months. So in this case, this is a patient who is 38 years old that came to the clinic, and you can note the inflammation and the heavy calculus deposits. And I'll show you now the radiographs, which shows more than 50% of bone loss generally all over that is more pronounced um, in the maxillary and the mandibular interiors. With a lot of furcation involvement, deep pockets. In this case, the patient was treated with a combination of surgical and non-surgical therapy. The patient was followed up for 5 years, and you can see here clinically, it's much better than the pre-treatment pictures, of course, but it's not excellent results due to the severity of the case initially. And on the x-rays, you can see the amount of bone loss that's still there, and several teeth are considered hopeless, and it was extracted actually later on. So a question that would come to mind here is what classification of this, which maintenance class is this patient? So from all the data and the pictures and radiographs, we can see that the patient had severe periodontal disease, more than 50% of bone loss. The results were not very good, although the patient had surgical and non-surgical treatment. Of course, it's stable, it's maintained, but again, the patient needed retreatment and had several teeth extracted. So would you consider this as a Class A, B, or C? I'm hoping that all of you guys got the right answer, which is Class C, of course. Okay, referral to the periodontist. One of the most important things during the maintenance or during initial visits of the patients that you have to know as a general dentist when you should treat the patient and when you should refer the patient to the periodontist. And this actually depends on two important factors: the extent of the periodontal deterioration, such as teeth with pockets of 5 millimeters or more that will need more than non surgical therapy due to the limitations of the instruments, and also the location of the periodontal deterioration, like teeth with furcation lesions that may be at risk, and there is more than 50% of bone support remaining. And this either will need a surgery or more extensive procedures that cannot be done um, by the general dentist. So these are examples of cases that you should consider referring to the periodontist. Any difficult case patients with systemic conditions, especially when it's uncontrolled. Dental implant patients, especially when it's multiple or a complete full mouth implants. Complex prosthetic constructions that require reliable results, surgery on the distal side of second row. So any patient who needs periodontal surgery, obviously you're going to need to refer them to the periodontist. As I mentioned, osteosurgery, regenerative surgery, and again the extent and location of the periodontal disease, which is the most important two factors. Deep pocket that will need probably open flap, debridement, teeth with furcation lesions, especially if they need guided tissue regeneration. So, an important question is, should maintenance phase therapy be performed by the general practitioner or by the specialist? So according to the classification of the maintenance patients that we've discussed before with class A, B, and C, each classification and each category will be advised to be seen by either the general dentist or the specialist, and we're gonna take a look here. So in this scheme, we determine which practitioner should perform the periodontal maintenance in patients with different degrees of periodontitis. So it makes sense that for class A, where it's mostly mild and good results, patient compliance is very good, that the maintenance appointment can be done and performed by the general dentist. While in the most severe maintenance category, where there's severe periodontal disease and extensive treatment was done, and we want to actually make sure that we need to maintain the stability of the periodontal condition, and most probably the patient will need retreatment and extraction and more period treatment. In this case, it's advised that class C will be seen by the specialist and the consultant, while with class B, it can actually alternate between the general dentist and the specialist. So we're almost in the end of the lecture, so it's very important for me just to highlight that the patient disease should dictate whether the general dentist or the specialist should perform the maintenance therapy, just to provide the proper treatment and next step to help the patient have a stable periodontal condition. Now we're going to go to the second part, which is the most important part here, is the assessment of treatment outcome. It's going to be in two parts, which is the prevention and treatment of gingivitis, prevention and treatment of loss of attachment, and then we're going to go to the conclusion and summary. Going to the first part, the prevention and treatment of gingivitis, we're going to mostly talk in this part through studies and epidemiological studies that have confirmed a close relationship between the incidence of gingivitis and the lack of oral hygiene. There are numerous number of long-term studies that have shown that gingival health can be maintained by a combination of effective oral hygiene maintenance and scaling procedure. One of the most important studies is the classic study by Lowe and co-workers that provided evidence on the association between oral hygiene and the incidence of gingivitis. So in this study, Healthy dental students were asked to refrain from any oral hygiene measures for 9 to 21 days. And what happened as a result of that is that they developed heavy accumulation of plaque and generalized mild gingivitis. When oral hygiene were reinstituted, the plaque in most of the areas disappeared within 1 to 2 days, and the gingival inflammation also disappeared approximately around 1 week after the plaque was removed. This actually concludes and gives us the result that gingivitis is a reversible disease and it can be resolved by daily effective plaque removal. Going now to the second part, which is the prevention of and treatment of loss of attachment. One of the famous studies was the longitudinal investigation to study the natural development of progression of periodontal disease between two different populations. We had the population from the Oslo, Norway, and the Sri Lanka tea laborers. So we had 565 healthy male from the Oslo, Norway, and 480 male tea laborers from Sri Lanka. The study results showed that the mean individual clinical attachment loss was around 1.5 millimeters in the Norway population, while it was actually 4.5 millimeters in the Sri Lanka tea laborers. It was 0.08 in the Norway population in the interproximal surfaces and 0.1 on the buccal surfaces versus 0.3 and 0.2 millimeters when it came to the poor tea laborers. This study suggests that without interferences, periodontal lesions were progressive continually and at a relatively even pace. Further analysis of the Sri Lankan laborers showed that they were not all losing attachment at the same rate, which was very interesting. The gingival areas showed inflammation, but attachment loss varied tremendously. And I'm going to show you here the classification of the 480 tea laborers according to the progression of the periodontal disease. You can see that 81% of the Sri Lanka tea laborers developed moderate periodontitis, while 11% had no periodontal disease, and only 8% had rapid severe periodontal disease. So they divided the Sri Lanka tea laborers based on the interproximal loss of attachment and tooth mortality into the rapid progression, where it was 8%, and they show that the clinical attachment loss was between 9 to 13 millimeters, while the moderate progression group were around 81%, and the clinical attachment loss was between 4 to 7 millimeters. And the last group was the no progression, and it was around 11%, and the clinical attachment loss was less than 1 millimeter. Therefore, under natural condition and in the absence of therapy, 89% of the Sri Lankan laborers had severe periodontitis that progressed at much greater rates than in the Norwegian group. Another longitudinal study of patients with moderate to advanced periodontal disease was conducted at the University of Michigan. This study showed that the progression of periodontal disease can be stopped for 3 years regardless of the modality of treatment. So with long-term observation, the average loss of attachment was only 0.3 millimeters over 7 years. This is very important because it indicated that a more favorable prognosis for treatment of advanced periodontal lesions that previously assumed can be actually happening. Another study was conducted in 75 patients with advanced periodontal disease to determine the effectiveness of plaque control. and surgical procedures on the establishment and maintenance of the stability of the periodontal health. The study showed that no further alveolar bone loss occurred during the 5-year observational period. And the most important conclusion was that the meticulous plaque control practiced by the patient in this study was considered the major factor in the excellent results, that there was no further bone loss. Okay. The 75 individuals were followed up after 14 years, and repeated examination demonstrated that the treatment of advanced forms of periodontal disease results in a clinically healthy periodontal condition and was maintained in most of the patients and sites during the 14-year period. Only a small number of sites lost a substantial amount of attachment. The frequency of sites that lost more than 2 mm of attachment during the 14 years of maintenance was 0.8 to 0.1% per year, which is actually a very promising result. Then we're going to mention a study on the progression of periodontal disease in the absence of therapy. In this study, we had two populations. We had Swedish adults with mild to moderate periodontal disease and American adults with advanced destructive disease. Okay. In the Swedish adults, 11.6% of all sites showed attachment loss more than 2 millimeter, which is 1.9% per year, while in the American adults with advanced destructive disease, it was 3.2% per year. Thus, the frequency of sites with disease progression was 20 to 30 times higher in the untreated group patients than in the treated and well-maintained groups described here. This highlights that the treatment is effective in reducing loss of attachment. Okay. So in summary, the prevalence of periodontal disease and the resulting high rate of tooth mortality have increased the need of effective treatment. And strong evidence now indicates that periodontal disease can contribute to numerous health problems, including pregnancy complications, heart disease, stroke, and diabetes. Available treatment is effective in preventing periodontal disease and stopping the progression, which is very important. And periodontal therapy does greatly reduce tooth mortality. Failure to diagnose and treat periodontal disease or to make periodontal treatment available for patients causes unnecessary dental problems and tooth loss and places the patient at risk for systemic health problems also. So for further questions, you can email me. And for references, it's actually chapter 69 and 70. Thank you so much, and good luck.